Boa noite a todos. O meu nome é Ricardo Leão. Estamos aqui hoje para dar início às nossas sessões sobre cancro da próstata. Hoje, dia 23 de setembro, são com o tema da vigilância ativa, o que é que nós devemos fazer a estes doentes que podemos eventualmente pôr em vigilância ativa. É uma honra, é um prazer estar aqui hoje convosco, mas sobretudo por poder estar com pessoas como o professor Estevão Lima, que é o coordenador nacional da urologia da CUF e que vai moderar esta sessão em conjunto com o Dr. Ferrito. Também obrigado por estar connosco, agradeço-lhe, é uma honra e um prazer. Portanto, alguns dos urologistas mais conhecidos portugueses e com ampla experiência no tratamento do cancro da próstata. O Dr. Ferrito é também diretor de serviço do Hospital da Urologia do Hospital Fernando da Fonseca e coordenador da CUF Tejo. Temos entre nós também um palestrante internacional que, para a sua apresentação, eu vou falar um bocadinho em inglês, não se importarem. So it's my pleasure to introduce you to Dr. Ardalan Ahmad. Dr. Ardalan Ahmad, I would like to say that it's a privilege for me to have him here with us today. He did his medical school in Iran, and after he moved to US to do his residency in urology, he worked in Albany, New York. After his residency, he came to Toronto for his SUO, Society of Urologic Oncology fellowship. He's one of the key leaders at this moment, and at least opinion leaders in terms of low-risk prostate cancer. He has several publications about this specific field, and I'll let him share with us his knowledge about this subject. Thank you very much, Ardalan.
Thank you, Ricardo, for the nice introduction. Hello, everyone. I hope all of you guys are doing well, especially your families, and thank you for joining us today. I will be talking about prostate cancer and active surveillance. Let me share my... I hope everybody's seeing my slides. So basically, I currently work in Toronto with Department of Urology and has been here for the past 5 years. So this is overview of my talk, a brief introduction on screening and epidemiology of prostate cancer. Then I will focus on why we think active surveillance is suitable for low-risk prostate cancer. I'll briefly present our data from Princess Margaret Cancer Center, and then focus on outcomes of delayed intervention after a period of active surveillance. I have a small touch, we'll be having a small touch on role of MRI, and as part of the active surveillance protocol. So, as you all know, prostate cancer is quite common. In fact, about 7% of men who were diagnosed with prostate cancer in 2018, that is 1.2 million men in 2018. However, there is significant variation in incidence and mortality of prostate cancer. As you know, in the westernized countries, there is a high incidence of prostate cancer compared to Asia and Africa. However, the majority of mortality actually occurs in Central America and Sub-Saharan Africa. The global trend of prostate cancer is actually shows that it's on the rise, and it's expected that prostate cancer will be increasing in incidence in the next 2 decades. However, when you look at continental level data, it looks like in North America, because of the widespread use of PSA, the incidence has been progressively decreasing, while in some parts of Europe and the rest of the world, the incidence is increasing. We know that since the introduction of the PSA as a screening tool for prostate cancer, the characteristics of prostate cancer diagnosed are changed. Now we mainly diagnose prostate cancer in younger men, average age is about 67, at lower stage and lower grade, and the treatment that we use, either radiation therapy and surgery, has been shown to be associated with lower risk of mortality with prostate cancer. However, this comes at a cost, mainly the stress and anxiety that the patient is exposed to. And we also know that the PSA screening has been associated with overdiagnosis and overtreatment. In fact, use of PSA is associated with a lead time bias of 6 to 12 years. More importantly, when you use PSA as a screening tool, we know that about 20, maybe 40% of men will be overdiagnosed with prostate cancer, meaning that they would have not been they will probably not suffer from consequences of having prostate cancer. And more importantly, maybe about 50 or half of the patients will be overtreated because of the diagnosis that was made based on PSA and subsequent biopsy. So why we think active surveillance is suitable for management of prostate cancer. One thing that I want to emphasize, and this is really important, is that active surveillance does not mean that we will not treat a patient. It's all about timing of the treatment, meaning that we will preserve quality of life, the first side effects associated with treatment, but in the meantime, we will try to preserve the window of cure for the patient. So all in all, it looks like, based on the data that I will present in the next few slides, that active surveillance is a very that basically alternative for treatment of low-risk prostate cancer with at least medium-term oncological outcomes that are comparable to either radical prostatectomy or radiation therapy. If you look at the major guidelines and basically available to us right now, you can see that across the board, every major guideline is accepting active surveillance as the preferred management for low-risk prostate cancer, and in some patients with intermediate-risk prostate cancer. This has resulted in a significant update of prostate cancer. The graph on the left is by Matt Cooperberg, showing that basically since 2010, there's a sharp increase in the number of patients managed with active surveillance, from a baseline of less than 10% to about 40, maybe 50%. In Canada, very much like Europe, almost 3/4 of men who are eligible for prostate cancer treatment with active surveillance, meaning low-risk prostate cancer, actually are offered surveillance and are managed with surveillance. So these are extremely good numbers overall that we have achieved in the past few years. This has actually been very important in reversing the decision of the U.S. Task Force against PSA screening for men with for men to have a prostate cancer screening from a grade D to a grade C, meaning that they now suggest that men between the ages of 55 to 69 should be offered PSA screening for prostate cancer diagnosis. So what is the rationale behind prostate cancer? I think when we look at the rationale, we should look at clinical data that we have, as well as molecular data or cellular level data. As far as clinical data is concerned, I do strongly believe that a pure Gleason 6 disease is very unlikely to metastasize or kill a man. And why do I say this? So if you look at the data that the Egner group basically published, looking at mortality rate of prostate cancer at 15 years in over 11,000 men who had radical prostatectomy, they found out that about 7% of these men actually died of prostate cancer, and the predictors of dying from prostate cancer were Gleason grade 4 or 5, high stage, meaning T3B or higher disease, and year of surgery. Interestingly, they find out that about 1% of their patients with Gleason 6 disease that had prostatectomy died of prostate cancer. However, when they look back and re-review the pathology, they come to realize that all of these were upgraded to Gleason 7 or higher disease. In a similar fashion, Ross and his colleagues look at over 14,000 patients with Gleason 6 or lower disease at radical prostatectomy who had lymph node dissection. As you can see, the number of patients with lymph node disease was minuscule at 22, and all of these patients were later on upgraded to higher Gleason grade disease on review of pathology. How about data that we have from the pre-PSA or post-PSA era? The Scandinavian group, looking at almost 700 men who were mainly intermediate to high-risk patients, and basically randomized them to observation versus radical prostatectomy. They published a follow-up at 13 years showing that showing that prostatectomy group has lower cancer mortality compared to the observation, but when they looked at factors associated with lower rate of mortality, the only two factors were actually younger age, less than 65, and having a prostate cancer diagnosis of Gleason grade 3 and higher. In the PSA era, we had the PIVOT and the PROTECT trial. The PIVOT, again, 700 patients. This time, most of the men were low-risk patients, randomized to observation versus radical prostatectomy, and one of the outcomes were prostate cancer mortality and overall mortality. There was no difference in prostate cancer mortality between the two cohorts. In the low-risk group, 7.4% versus 11%. However, overall survival was improved in the surgery group for patients who had a PSA more than 10 or had intermediate risk group. In the PROTECT trial, over 1,600 patients randomized to 3 groups, we know that at 10 years, there was no difference in prostate cancer mortality, although active monitoring was associated with higher rate of metastasis. So how about molecular level or cellular level data? We know that a cancer cell or a cancer should be able to proliferate, should be able to locally invade and metastasize, should be able to make its own blood vessels and prevent growth suppressors and be resistant to cell death, while potentially can replicate itself fast. This table, which I basically borrow from Dr. Klotz, is comparing Gleason pattern 3 and 4 as far as the tissue markers of invasion, metastasis, and prostate cancer mortality are concerned. As you can see, in this column, Gleason pattern 3, there is virtually either these markers are not present or expressed in very small volumes or values. So all in all, it looks like both clinically and at the same time from molecular standpoint, not all patients with prostate cancer need active treatment, and some can be managed conservatively. And when we say conservative management, obviously we look at life expectancy of the patient or their comorbidities. In this setting, we usually would like to preserve this type of treatment for patients who are healthy enough and have a life expectancy of at least 10 years. Active surveillance does not mean that we will leave the patient be, but rather actively interfering with the course of the disease by measuring their PSA, doing DREs, biopsies, and more recently MRI and maybe genomic markers in the future. Now, as I mentioned earlier, the main goal of active surveillance is maintenance of quality of life while we are delaying or avoiding side effects associated with treatment and preserving potential treatment either in the form of radical prostatectomy, radiation therapy, and more recently focal therapy for the one patient that needs treatment. So this is the Nccn guideline table for risk stratification of patients. As you can see, the ones that are highlighted are groups of patients that are suitable and that I believe are suitable for active surveillance, very low risk, and maybe favorable intermediate risk prostate cancer group. I'll mainly focus on the outcomes of the first 2 groups and will touch very lightly on the favorable risk group later on. This is a table that you probably have seen multiple times. These are the major or the most famous active surveillance prospective cohorts. There is Johns Hopkins cohorts on the top and University of Toronto in the middle. I do want you to look at their inclusion criteria. As you can see, the Hopkins group has very strict criteria for enrolling patients in active surveillance, also for surveillance after enrollment. On the other hand, University of Toronto group, which Dr. Klotz has been in charge of it, is more inclusive type of criteria for inclusion, meaning their inclusion criteria are not as strict and the surveillance is not as strict as the Hopkins group. This comes to be important later on when we get to the outcomes of active surveillance. The cohort as far as treatment-free overall survival, and cancer-specific survival are of our concern. So what do we do in Princess Margaret? This is a different cohort. First of all, I have to say this is a different cohort from Dr. Kloss' cohort. This is mainly done at Princess Margaret and Toronto General Hospital, as well as Mount Sinai. We have very similar eligibility criteria, maybe a little bit more strict. PSA, we keep it less than 10. CTA, clinical stage less than T2. Only Gleason 6, number of cores less than 3. And each core less than 50%, and usually want the patient to be less than 75 years of age. Saying so, I have to make a notation that for the past few years, we have increased our eligibility criteria to include more patients with Gleason 6 disease. I'm sorry, with higher volume Gleason 6 disease. This is our surveillance protocol. Pretty much standard. Everybody gets a confirmatory biopsy at 12 to 18 months. We do follow the patients with PSAs and DREs and surveillance biopsies every 1 to 3 years after the confirmatory biopsy, beginning 2016, maybe late 2015. Excuse me. We have incorporated MRI in our protocol. It's not standard, still at discretion of the physician, but I can tell you that more and more we're using in our clinical practice. Obviously, if a patient is not fulfilling active surveillance criteria, or they're reaching 75 to 80 years of age, or they're refusing active surveillance, they will be excluded and referred for treatment. So, as I mentioned, this is a prospectively maintained cohort. The data is a bit old. We looked at it back in 2016. About 1,500 patients were at the time enrolled. Right now, we have probably 2,300 patients. Median age was about 63, PSA of 5, and median time to confirmatory biopsy was 13 months. Overall follow-up was close to 6 years. And majority of patients, as I mentioned earlier, about 71% were low risk or very low risk patients. So this graph shows the cumulative incidence of progression, overall grade progression, and progression to treatment. So at 5 years, overall progression is about 27%, while treatment is about 22%. This is very much consistent with the findings of other studies. I'll come to that table again later on. But what I want to highlight is during the 6 years of follow-up in the large cohort of patients, only 2 patients died of prostate cancer, and 7 patients developed metastatic disease. As you can see, the overall cancer-specific and metastasis-free survival is quite excellent. All of them above 96%. And this is, as I said, very consistent with what we have from other groups. This is the table that summarizes the outcomes of the active surveillance cohorts that I already mentioned earlier. Again, University of Toronto and Johns Hopkins are the ones that I want you to focus on, but overall, with the median follow-up ranging between 2 to 8 years, you can see that at 5 years, the rate of treatment or being free of treatment is about 20 to 40%. Here, one important, basically, outcome that you have to look at is the prostate cancer mortality. The University of Toronto at 15 years, about 5% compared to 0.1% at 15 years from Hopkins. The main reason for this difference was the inclusion criteria that I mentioned earlier. Early on, the University of Toronto cohort, they did include Gleason 7 disease, and starting about 1999, they come to realize that they have to, 2009, they come to realize that the majority of the patients who die of the disease later on are actually Gleason 7 patients, or the patients who were upgraded to Gleason 7. So from that point on, they basically limited the inclusion of Gleason 7 disease only to patients with less than 10 years of life expectancy and less than 5 to 10% of Gleason pattern 4 on their biopsy. So, all in all, I think we have a significant amount of data about 15, maybe 20,000 patients so far, who were managed on average between 3 to 8 years of, who were managed with active surveillance between 3 to 8 years on average. And the mortality has been quite low, rate of metastasis is quite low, but they do occur. But they do occur. However, most patients are doing well. About 20 to 30% at 5 years and maybe 40 to 50% at 10 years will require treatment. This is the group that you commonly ask yourself, or the patient asks you, so doctor, what if I progress? Did I lose anything? Or was the delay in treatment associated with worse outcomes? So I'm basically going to focus on this cohort of patients. I do like to talk about misattribution and true progression. We know that at initial biopsy, if you do a systematic biopsy, there's about 20 to 30% chance that you're missing a higher risk group disease. However, risk of true progression, meaning going from Gleason 6 to Gleason 7 disease overall, is quite low. There have been multiple studies done about trying to predict the true risk of progression using Markov models, and the estimated rate is about 1 to 2%. And majority of the time, actually, when you have a higher volume Gleason 6 disease, these are the patients who will progress. In other words, very low risk patients are less likely to progress from Gleason 6 to Gleason 7 disease. So once again, this table shows the rate of treatment at 5 years. The numbers are about 20 to 40%, depending on what is the criteria used to define progression and offer treatment. This is the first paper we published a few years back in 2013 from our own cohort. At the time, we had about 440 patients managed with active surveillance. 41 of these, or 10%, progressed to radical prostatectomy for different reasons, including patient anxiety, volume progression, and grade progression. To compare the result or outcomes, mainly pathology outcome as well as biochemical recurrence outcomes and functional outcomes, we created 2 risk groups or control groups. These 41 patients were matched with a cohort of Gleason 6 disease patients at diagnosis who had immediate radical prostatectomy. So 41 and 112. Then we did a sub-analysis using the patients who progressed to Gleason 7 while on active surveillance and matched them to patients who were treated for Gleason 7 disease immediately at diagnosis. As I mentioned, we looked at pathology, oncology, and functional outcomes. So overall, when you compare patients who undergo radical prostatectomy immediately compared to patients who had delayed radical prostatectomy, and this has been shown in multiple series, the rate of adverse pathology is worse in active surveillance cohort. There's high rate of PT3 disease, extraprostatic extension, positive margin disease, and Gleason 7 or higher disease. However, when you focus just on patients who progress to Gleason 7 and compare them to patients with de novo Gleason 7, there is no difference in adverse pathology outcomes between these 2 groups. We did look at the biochemical recurrence at the time. Our median follow-up was about 6.1 years. And there is a table that is missing on this PDF presentation, but you may be able to see it on this side. The rate of adjuvant radiation therapy, salvage radiation therapy in both cohorts were similar. And the Kaplan-Meier graph shows that there is no difference between the 2 cohorts in regards to biochemical recurrence. This Kaplan-Meier graph compares patients who had delayed radical prostatectomy, that 41 patient that I talked about, with 112 who had immediate radical prostatectomy. So initial basically outcomes show that there is no difference. Next, actually this year and this September, we published a more robust group of patients with active surveillance who end up having radical prostatectomy. As I mentioned earlier, we now do offer active surveillance to high volume prostate cancer patients. So we decided to just focus on patient who progressed to Gleason 7 disease, because we think these are the ones that may suffer from delayed treatment compared to a patient who had immediate radical prostatectomy. So overall, between 92 and 2015, we had almost 1,500 patients who were managed with radical prostatectomy. And out of these, about 300 end up having radical prostatectomy for different reasons. As I mentioned, we focused on the ones who had Gleason grade 2 or higher at the time of progression, and there were 170 of these patients. Our primary outcome was pathology outcome, but we did look at biochemical recurrence, overall survival, and cancer-specific survival as well. So this is the diagnostic characteristic of our patients. Median age was almost 62, PSA of 5.5. Majority of patients were T1 disease, and all of them had Gleason 6 disease as diagnosis. They spent about 31 months on active surveillance, and on average, they had 2 biopsies done while they were on active surveillance prior to going for radical prostatectomy. Once again, as I mentioned earlier, we did compare this cohort to a matched cohort of patients, meaning that we identify from our radical prostatectomy database patient who had radical prostatectomy within 6 months of diagnosis, and matched them based on urobiopsy, age, PSA, total Gleason score, and primary pattern Gleason score. This table shows that our matching was quite successful, except that the patient with active surveillance had lower cancer volume compared to the patient who had de novo Gleason 7 disease. As I mentioned, our primary outcome was rate of adverse pathology, meaning T3 and higher disease, T3B and higher disease, positive surgical margin, no positive disease, as well as extraprostatic extension. All of these outcomes, there's no difference. Basically, similar rate of T3 disease, similar rate of positive margin rate, nodal invasion and seminal vesicle invasion, as well as extraprostatic invasion. And the only difference between the two cohorts was smaller cancer volume in the active surveillance cohort. Its cohort were followed 5.6 years after the radical prostatectomy. Only 1 patient in the active surveillance cohort died of prostate cancer, and the biochemical recurrence rate was again similar to the previous cohort. Were similar between the two cohorts. This table shows the rate of adjuvant therapy and salvage therapy. Once again, we didn't find any differences, although in the de novo group, it looks like that there is a higher rate of metastatic disease, but this was the numbers are too small, so we did not look into this further. What we did was looking at overall survival and cancer-specific survival at 5 years. It's not a long duration of follow-up, considering the basically the course of prostate cancer. However, there's no difference, and at 5 years, cancer-specific survival was 100%, and overall survival was 98% in the active surveillance cohort after radical prostatectomy. This is a Kaplan-Meier curve comparing the biochemical recurrence between the two cohorts, and as I mentioned earlier, there was no difference between the two of them. We wanted to know if being on active surveillance or the duration of active surveillance will affect the rate, is a predictor of adverse pathology and biochemical recurrence. In this table, you can see that being on active surveillance was not a predictor, and was not a predictor of adverse pathology. The only predictor were basically Gleason group at the time of progression, as well as PSA density. Next slide looks at association of biochemical recurrence and being on active surveillance. Once again, there was no difference. We did look at these two outcomes in 2 different ways, and ultimately decided that using a multivariate model, either the Cox model or the regression model was the better way to present our data. And in both situations, there was no association between being on active surveillance or the duration of active surveillance and having adverse pathology or biochemical recurrence. So how about radiation therapy? A couple of years ago, we had we collaborated with our radiation oncology colleagues, namely Dr. Berlin, to look at the radiation therapy outcomes after a period of active surveillance. Very similar outcomes were looked at, except that we couldn't look at pathology. So we looked at biochemical recurrence, metastasis-free survival, and overall and cancer-specific survival. About 200 of our patients progressed to radiation therapy while on active surveillance. Again, we did create a matching group for these 200 patients. Our matching criteria was much more strict. Besides age and PSA, we did use clinical stage, primary and total Gleason pattern, as well as NCCN risk category and the type of treatment they got, either low-dose brachytherapy or external beam radiotherapy. This table shows that the two cohorts, this is the low-dose brachytherapy and IGRT, they were very well balanced between the immediate treatment cohort and the delayed cohort, and there was no difference between the two of them. Our median follow-up was actually close to 7 years, and as you can see in the cumulative graphs, there was no difference in biochemical recurrence rate. We did further look at favorable risk, at intermediate risk group, and compare the biochemical recurrence rate in the favorable and unfavorable pathology. In the favorable pathology, there was no difference between the two cohorts. However, it does look like the patients who present with unfavorable disease tend to do worse compared to the ones who progress to unfavorable low-risk prostate cancer while on active surveillance. So how about MRI? I have to say this is going to be very brief. I think there are two questions that one should ask. Whether the first question is, can MRI incorporated as part of active surveillance? There is tons and tons of data, randomized trial, showing that MRI targeted biopsy is superior to systematic biopsy in diagnosing clinically significant prostate cancer. So we definitely can use the same, basically expand from what we know and use it in active surveillance. But to be more specific, the only trial in this setting that I'm aware of, and this is the ASSIST trial by Dr. Klotz. There's two publications, one in 2019 and one in 2020. They basically included 296 patients with low-risk prostate cancer who were eligible for active surveillance and randomized them to get an MRI prior to their confirmatory biopsy. And then everybody got systematic or targeted biopsy depending on which group they were part of. So their initial outcome of interest was changes in rate of upgrading on confirmatory biopsy, or the difference between the two cohorts. There were 3 centers involved with 3 different level of expertise. And I don't know if I said unfortunately, but as you can see, there was no difference in the rate of upgrading on confirmatory biopsy when you incorporate MRI prior to this biopsy. Initially, they looked at rate of progression-free survival as well as treatment-free survival at 1 year at 1 year of follow-up, and there was no difference. But when they looked at the 2-year follow-up, meaning that patients who remain on active surveillance and get a second-year biopsy, there tend to be fewer men on active surveillance. There tend to be fewer men on active surveillance who failed the active surveillance if they had MRI in the past, meaning that systematic biopsy group tend to do worse. This is one. The second question that comes to, so the answer to the question should be yes. I think MRI is here to stay. It's just a matter of how to use it, and I think it's reasonable to add MRI to be in between the confirmatory and initial diagnostic biopsy, just to ensure that you're selecting the appropriate patient for active surveillance. The second question that comes to mind is what to do afterwards. Can we use MRI as a surveillance tool and to omit biopsies? We know it's hard for the patients to undergo biopsies, and many times they come to the office and they basically argue with you that why am I getting a biopsy, why my PSA has not changed. So what about looking at the MRI as a replacement for biopsy tools. There are multiple studies, again, that I'm just highlighting two of them. One is from UCSF, looking at the role of MRI alone in detecting grade 3 classification. What they did, he had about 300 patients who were 400 patients who were diagnosed with prostate cancer and low risk. And they got an MRI at some point during their surveillance, either before confirmatory biopsy or afterwards. And they followed them with up to 4 biopsies after the MRI. And they looked at the rate of basically how well MRI does in finding changes in grade, and whether we should use MRI as a tool to monitor patients. As you can see, the overall negative predictive value is pretty much consistent with what we know, about 80% with a sensitivity of 89%. Interestingly, if someone has a PSA density of more than 0.15, the negative predictive value of MRI drops down quite significantly to about 65%. Another study, this is coming from Memorial, they went a step further and basically look at MRI to see if changes in MRI is a suitable way to decide if a patient should be biopsied or not. I know from clinical practice, many times we start a patient in MRI. If there is basically Pyrite 4 or 5 lesion or Liquid 4 or 5 lesion, we will send them for biopsy. But for Liquid 3 or Pyrite 3 lesion, unless their PSA density is quite high, we will just watch them. So we want to know if this patient next year or 18 months from now had MRI, should we just rely on MRI to decide whether he should have a biopsy or not. So interestingly, if you do that, meaning that if you just use MRI as the only tool to decide who should have biopsy or not, and say a positive MRI is any lesion or any Liquid or Pyrite lesion of 3 or higher, you will avoid 348 biopsies out of 300 patients that they had. However, in 31% of patients who actually progressed, you're going to be missing Gleason grade 2 or higher disease. What if you focus on changes in MRI? So let's say the patient has no change in their MRI findings and you decide not to do a biopsy. You will be missing 32% of patients who progressed. And the way they actually look at this was they did biopsy everyone at the end of 3 years of follow-up. So it was either for-cause biopsy or for per-schedule biopsy. So 32% will be missed. How about patients who show a change in their MRI from a Pyrite 3 to 4 or 5? If you just focus on them and don't biopsy the patients who have not shown any increase in the number, you're still missing between 28 to 64% of patients with Gleason grade 2 or higher disease. So significant number of patients will be missed. Does this have clinical consequence? We don't really know. There's a study that I don't have here, but I know the Dr. Emberton's group at King's College Hospital, they just recently published the result of 5 years of follow-up based on changes in active surveillance, meaning they just biopsy patients for cause, either PSA changes or MRI changes. And they show that there is no difference in rate of upgrading, and MRI can be replaced for biopsy. But the problem with that is when you don't biopsy someone, you don't know if they progressed or not. And the follow-up is quite short. 5 years is pretty much nothing in the history of prostate cancer. So I think we need more data to mature to make sure that we are actually capturing and we are utilizing the MRI adequately. The one other thing I would like to mention is MRI is a tool, and with any tool there is significant variability. So you need to have a very good scan. You need to have a very good interpreter who marks the lesion for you if you're doing a biopsy. And all of these two variables makes it really hard for MRI to be widely replaced. The MRI to widely replace biopsy. So at this point, I would probably say it's not safe to just go with the MRI and omit the biopsy. I think the best and safest way to monitor the patient is do the MRIs every 1 to 2 years and at every 3 to 5 years do a biopsy no matter what to assure that you're not missing the big picture and the patient is not suffering. I think this is basically what I wanted to talk. I would be happy to take any questions, and I hope you enjoyed it.
So, can I start my...
Sure, happy to do.
So first I would like to, this is a great pleasure to be here in this online session. It's a very fantastic topic. Is nice to speak about active surveillance together with my colleagues, Dr. Ferrito, and the chairman and host, Recurrence. So there are a lot of questions that I need to do, but
Sure.
I start with how to select the patients. Nowadays, active surveillance is established approach in patients with low risk prostate cancer. The question that I need to ask, and for me is the most important, is what criteria should be used to select the patients for active surveillance? There are two studies that represent the extremes of the criteria. One of the extreme is the Toronto group, and probably you are in this group, and is a study published in 2015 in Journal of Clinical Oncology, and it is a study that is very inclusive. Okay, and there another group is Option group, is very restrictive.
Mm-hmm.
Nowadays, for you, what criteria should be used to select the patients in this moment? This is the first question, and after this is in sequence is what do you think about about the genetic studies should be included in patient selection criteria for active surveillance?
Mm-hmm.
We know that there are some patients with BRCA2 positive. Nowadays, there are a lot of risk for development of prostate cancer. And in my opinion, probably in this moment, is like MRI, probably genetic studies is and a patient with some genetics problems is exclusion criteria for active surveillance. So, what criteria should be used to select the patient in this moment?
Sure. So I think this is a discussion that, first of all, it's a very good question. But to answer your question, I think this is a discussion that you should bring to your patient, and also think about how much risk you're willing to take. As I showed, there is risk of dying of prostate cancer. There's risk of having metastatic disease while on active surveillance. What is the risk? It's less than 1% and 0.2%. So there are patients who will die. It doesn't matter how you follow them. Even in the Hopkins cohort, there's 0.1% out of almost 1,800. That is almost 18 patients. So patients do die. But what criteria I think we should use? I don't think going too strict is the answer. It means when you go too strict, you're basically risking overtreatment again, and we're going to be in the same position in a few years. You're just picking up about 15% of patients rather than 40% to 50% for active surveillance. And you're going to get basically faulted for not using active surveillance as much. So I think overall, any very low-risk patient is a very good candidate for active surveillance. When it comes to low-risk patients, meaning that you have patients who have higher volume of disease, maybe more than 3 cores, maybe the PSA is a tad higher than usual. These are the ones that you get concerned, because we know that high volume disease is associated with high risk of progression and also high risk of having adverse pathology if they undergo radical prostatectomy. So in this group, I think I would definitely consider MRI from the get-go after the initial diagnostic biopsy, because I don't want to put them on active surveillance if they're really not a good candidate. Then the other question that kind of hidden in your question, the other answer that is kind of hidden in your question is, how about surveillance? We know that Hopkins group used to do surveillance biopsies every year. And I'm sure you know it is very hard to convince a patient to have a biopsy every year when their PSA has not changed and they are doing fine. The other caveat is also risk of infection, 4 to 6%. We still mostly do transrectal biopsies, and the risk is real and serious. So the Hopkins group actually changed their criteria for surveillance to every 2 years of biopsy based on the study that was recently published in Cancer Journal. Basically, all well-known people in active surveillance, they come together, use the University of Toronto, Hopkins, and UCSF cohort, as well as the SPCG4 cohort, to compare decreased risk of mortality from prostate cancer based on surveillance biopsy. So what they show that at 20 years, having surveillance biopsy definitely brings down the risk of mortality from prostate cancer about 3 to 5%. Then they looked at how frequently you should do biopsies, and they looked at 1, 3, and 5 years, and there's no difference. Just having one surveillance biopsy basically saves you from dying from prostate cancer. Based on that recommendation now, the Hopkins group is basically doing every 2 years of biopsy on surveillance. The second question you ask is about genetic markers. So there is a range of genetic or basically markers that you can use. There are serum marker that you can use like 4K score, Phi score. There are urinary markers like PCA3, and then there's genomic markers. So there is no specific study looking at any of these markers in a prospective manner. All that has been published is retrospective. We know that if you use 4K score, for example, in active surveillance cohort, it is it can tell you which patients are probably having a higher risk disease at radical prostatectomy, but it does not tell you who is going to progress on confirmatory or surveillance biopsy. There is no study on Phi. When you look at PCA3 studies, we actually published our results a few years back, looking at PCA3 in combination with MRI or 4K in combination with MRI. And if the two tests are negative, the risk of harboring high-risk disease at radical prostatectomy is barely there. Like the numbers are less than 5%. So that's another marker. But more commonly, the markers that we have are deciphered, and when we have Oncotype DX and we have Polaris. These are the three that has been shown in different settings that are predictive of adverse pathology, metastasis rate, and dying of prostate cancer. Again, none of these have been specifically looked at in prostate cancer and active surveillance. The Canary Pass cohort, as well as the UCSF, look at Oncotype DX. And they did show that in a multivariable model, use of these markers is a predictor of adverse pathology, as well as, adverse pathology at RP. The UCSF cohort shows it can be used to predict adverse pathology at biopsy, but the Canary Pass cohort could not show that. If you look at the ROC curves, the sensitivity of this model goes from 68% to 70 or maybe 71%. So there's less than 5% change in your model if you're just using clinical factors, but then add these markers to them. So I don't think we should use them for everyone. And I think the ASCO guidelines or recommendation does state that there is not much to gain from offering this to all patients, but reserve them for certain patients that you are kind of on defense to offer them active surveillance. Who are these patients? I think if you're offering a patient active surveillance with Gle77 disease, I would suggest that you should use a genomic marker. And which one you use? You can use either Oncotype DX or Polaris. If you're using it for a high volume disease, PSA density that is high, I do also suggest that you should consider it. And the third part of your question was about BRCA mutations. Obviously, we look into family history and based on that, decide to do genetic testing to find BRCA disease. And we know that if you have BRCA, you're younger when you're diagnosed with prostate cancer and you will have a more aggressive course. I was in Barcelona last year, and this was actually published by Mark Curve from Israel. They have a small cohort of patients with BRCA2 prostate cancer on active surveillance, about 14 or maybe 16 months of surveillance, and they are actually doing fine. But obviously, 1 to 2 years of follow-up is not enough. Their rate of progression is pretty much similar to someone who does not have a BRCA mutation. But as I said, it's just 16 months of follow-up. So if you have a BRCA positive patient, I do not recommend at this time to offer them surveillance, or at least let them know that they are at high risk of progression and need to be monitored more closely. These are the ones who will do the MRI, do the biopsy every year, because they can skip they can be basically the ship, the wolf in the ship cover.
But do you agree in this moment we can include the genetic studies in the protocol for selection of the patient, the BRCA for this?
I think we should, yes. There's a huge cost associated with it, but I don't think, if you're, it's all about selection. I don't think if you have let's say a 60-year-old, you have one core Gleason 6 less than 20%, I would not offer it to him. But if there's a strong family history, especially people dying of prostate cancer, or if there is Gleason 7, 8, 9% pattern 4, or high volume Gleason 6, I think it's reasonable to offer it to them because it will change your management.
And in your opinion, can a black man or a family history of prostate cancer be exclusion criteria for active surveillance?
Very good question. Both of these questions have been looked at. Just having family history of prostate cancer should not be an exclusion criteria. There's no difference in rate of progressions or adverse events with having a family history of prostate cancer. If you tell me somebody has basically family history of prostate cancer and dying of prostate cancer, especially early on in prostate cancer, these are basically the clues you're telling me that I have to take a look at the BRCA status and also use the genomic markers. So to answer your question, if somebody had family history in their family, I would still offer them active surveillance. The second part of your question was race. Very interesting question. The data from Hopkins shows that if you are African American or basically your African ancestry, rate of upgrading is actually associated with your race, meaning that compared to a Caucasian man, you're almost 30% at high risk of progression. At the same time, the University of San Francisco, California, actually published the data maybe a couple of months ago, no, 3 months ago, and they showed there is no association. All in all, it does not look like that race should be a factor, but I think the data is not mature and we don't have enough to say about it.
Ahmad, you disappear. So Ahmad disappear. Ricardo, there are a lot of questions from the audience. I don't know if you needed to.
I cannot see them, and some of them, if their questions are in Portuguese, so I cannot read them.
If you hear, I think is we can.
Dr. Ferreira,
Yes.
is Dr. Ferreira there?
Okay.
Dr. Ferreira, can
Good
you
evening.
see the page? Questions?
Yes. First of all, I'm very pleasure for me to be invited by Ricardo for this meeting. I want to tell my congratulations to our colleague from Toronto for his excellent presentation about active surveillance, because you say in this 20 minutes all we have to know about nowadays active surveillance. We have some questions from audience. I would like to put some questions from audience. Some of them you answered meanwhile, but for me the what is concerned to me about active surveillance is how we can schedule the active surveillance about what is the value of PSA, if the kinetic of PSA has any value, and what means the MRI in this way, if we need to do a confirmatory MRI, when do we do in criteria for active surveillance at the beginning, MRI with biopsy to confirm the criteria for active surveillance, and it's some questions that we don't have the answers to confirm our doubts about this, and how we deal with the patients, with Latin patients, to live with a cancer that we don't know if it progress, and to tell the patients that he can live with a tumor that don't kill him, that neither go to metastasis. So it is not easy in our populations to deal with these problems. So I put some for your consideration, some questions from all this. Our colleague Frederic Furiel put the questions about a young man. If we think that it is to recommend active surveillance in a man before 50 years old. I personally think that the age, it's not the problem major, but I would like to hear your opinion about this question.
Definitely. So from what I understand, one part of the question was, do we look at PSA kinetics? So actually the U of T cohort, initially before 2009, they included PSA kinetics, meaning PSA doubling time of less than 3 years versus more than 3 years, as a criteria for progression. However, when they do compare patients who had PSA doubling time less than 3 years to more than 3 years, the only thing that PSA kinetics showed us is that if you're having a patient that his PSA is going up rapidly, they are at high risk of progression. It does not affect other outcomes much. So we do not currently use PSA kinetics as a reason to offer treatment. We do use PSA kinetics to further work up the patient, either with MRI or a biopsy. That was one part. The last part that I remember, and I'm going to talk about it, is whether age should be a factor. This has been also looked at quite extensively. More recently, there are two publications looking at the same question. One is from Canary Pass, the other one is from UCSF. And they look at rate of progression in patients less than 60 years compared to more than 60 years. We know that prostate cancer is more aggressive and higher grade as you get older. So just based on what we know, I did not expect that it is going to change. And in fact, both studies showed that patients who are younger than 60 are at less likely chance of progressing, though they have a much longer period of time to progress. So basically, compared to older men, a man who's younger than 60 is less likely to progress under confirmatory or surveillance biopsies. But obviously, if you're 55 and you're expected to live 85 years, you have 30 years compared to someone who's going to be living only 10 or 15 years. The third question was patient anxiety. So if you look at surveillance data from early on, maybe 2007, 2008, I still remember at the time I was at UCSF, people saying, oh, about a third of patients get so anxious that they want to come off of this surveillance and they want treatment. As we got better, as the data matured up, we could discuss this with the patients, and patients are started noticing, okay, why should I lose my erection? Why should I be leaking urine or miserable running to the washroom because I had radiation therapy while I can safely be watched? So now the rates of anxiety-induced radical treatment is about 3 to 5%, depending on which group you're looking at. But very importantly, and I think this was a very nicely done study from Memorial a year ago, maybe. They basically, for all their providers that are managing active patients with prostate cancer, they provided this short course, how to discuss treatment options with a patient. And then they looked at the uptake of active surveillance out of this course. So prior to the course, less than 40% of the patients were happy to go on active surveillance. And just by this very small intervention and the way the provider talks to the patient and provides them with the data, their uptake goes up to about 80%. So it really depends on how you approach your patient. What do you want to tell them, and what do you not? And try to basically take away that anxiety associated with with knowing that you have cancer. Another question that comes to mind is, well, do patients on active surveillance are more anxious than people who had treatment? And very interestingly, the highest anxiety is at the time of diagnosis. And then when you compare active surveillance patients to patients who were treated, the rate of anxiety and basically thinking about their disease is much lower in the patient who are active surveillance. So all in all, it does look like being supportive, providing adequate data, depending on your patient, is the way to go. Obviously, there are patients who are going to be anxious and they got treated. Nobody can say, oh, none of our patients are with low-risk disease are not going to get treated. And I think it really depends on how you approach it and how comfortable you are talking with your patient. I have some questions that I can see here. Dr. Costa basically saying, if you have a low-risk patient with an MRI grade 4 or 5 and on target biopsy they don't show upgrade, would you still consider active surveillance? I think if you're pretty much sure you hit the target, yes, you should consider it, knowing that I would continue following up a bit closer. I will do an MRI next year, and I would biopsy them again more frequently. We know that if you see a visible lesion, although it's Gleason 6, is at high risk of progression. So to answer your question, they are just more likely to progress, so they need closer watch. Dr. Silva, concerning the definition of low-risk prostate cancer, do you think the introduction of MRI target biopsy will have an impact on the definition of low-risk disease? Will the number of patients with low-risk disease decrease? So if you look at the MRI data, we come to realize that adding MRI to systematic biopsy has increased basically sensitivity of the test from about 50% to 70%. So obviously we're gonna, and this is for diagnosing clinically significant prostate cancer, obviously we're gonna have less low-risk disease patients. Many of these low-risk disease patients are still Gleason 6s with high volume disease. But remember, we used to diagnose 60, maybe 70% of patients with Gleason 6. So 10 to 20% less is still about 50% of our patients. So we still have a huge number of patients that may be suitable for active surveillance. Dr. Greca is asking, what do you think about the comparison choice between liquid biopsy or MRI before solid biopsy? I think I did discuss this very briefly. If you use either 4K score or PCA3 or Phi in combination with MRI especially, there is the negative predictive value, if both tests are negative, is about 95%. So I do believe if you don't want to biopsy someone, using these two may be the way to go. Which biomarker you think help deciding for active surveillance in low-risk prostate cancer? So again, I think not everybody needs biomarker testing. But if you want to consider biomarker testing, I think either Oncotype DX or Prolaris are the ones to go. And there's a lot of data supporting that. And also, I think there was a paper from a couple of years ago from European Urology. Basically, there's a flow chart on how to do, and the European and the EUAU also recommend these two, as far as I know. Dr. Bernardino has another question. Do you believe in MRI for AS without confirmatory biopsy? I did talk about this extensively. The only time I would consider omitting confirmatory biopsy is if a patient has MRI for diagnostic biopsy and they have very low risk disease. Otherwise, I do not think it's safe to just ignore confirmatory biopsy. Would you recommend age? It was the question that we just talked about. I think if anyone will benefit from active surveillance, as far as functionality goes, is a man less than 50 years of age. As I said, I don't think there is any man who wants to leak or cannot have erection, especially that young. Which patients with low risk you wouldn't put on active surveillance? I think my first choice is always active surveillance. I'll talk to them, but obviously, if they are, I'm not clear on your question in the sense of volume, but if they have a lot of Gleason 6, or if they have a Gleason 6 with very small amount of Gleason 4, these are the ones that I will be hesitant to put on active surveillance. If I decide to, or if the patient pushes for it, I will definitely get an MRI. And I'll try to have a genomic marker, though it's very costly and it's out of pocket in Canada. It's about $3,500 in US dollars, which is 4,200 Canadian. It's a huge cost, so I would be hesitant to offer it to everyone. I think those are all the questions that I can see.
You already answered all the questions. And I have another question.
Sure.
So, to finish, and I would like to ask you if you already perform a prostatectomy in a patient with a multiple prostatic biopsies. And because for me, the main obstacle in adoption of active surveillance is, for instance, a very young patient with a prostate cancer, and after many years and after many prostate biopsies need nerve sparing surgery. You show me fantastic results, oncological results with a definitive therapy after active surveillance, and results of the erectile function, results, okay, of nerve sparing results after active surveillance with multiple biopsies.
Sure.
Can you answer me this? And for me, because a young patient okay? A lot of biopsies, and after 10 years, need to maintain erectile function. And you have the opportunity, a window of opportunity with a good surgeon, with a good technique, robot, to perform a nerve-sparing, fantastic surgery.
Sure.
What do you think of this?
Okay, so there is a huge discussion about this, the number of biopsies and how difficult the prostatectomy is going to be. There is a lot of publication actually in favor of that, and there is a lot of publication saying, no, it's not true. So I think you highlighted the most important thing is your expertise. I do understand, and I've seen it, people who had multiple biopsies, the plane between the rectum and the prostate is difficult to dissect. The nerve dissection is going to be more difficult. But however, it's not impossible. When you look retrospectively, it will say maybe it was more difficult, but at the same time, you don't know, because it could have been difficult from the get-go. How would you say it was not? It could have. It is his biology. I have to basically say I agree it may be tougher, but I don't think that should be a reason not to offer it to a patient. You should discuss it if you think your experience basically says that the prostatectomy, as well as far as nerve sparing is concerned, is going to be more difficult. You should discuss it with your patient, and if he is willing to go for prostatectomy, and early on, you should go. From experience and from what I know, unfortunately, we did not look at functional outcome, because when I tried to look at it, it was basically based on the clinic note, and it was not a reliable way to present it. But from all comers in our center, like irrespective of baseline age and functionality, we know radical prostatectomy causes erectile dysfunction about half of the times. So I don't see any reason that someone who was in active surveillance is going to have higher risk of being not able to have erections. But at the end of the day, you're an experienced surgeon. I think you're the one who decide which patient is going to get better, going to have good outcomes, and your skills are the ones that makes a difference beside the patient characteristics.
And another question. What
Sure.
is your opinion about the economic cost of active surveillance?
Okay.
Protocols with it, MRI, annual biopsies, now genetic studies.
Okay, so good question. The studies I'm aware of, a lot of the studies were done before.
Very expensive, huh? MRI, biopsies, genetic studies, huh?
There is actually published data from Europe and North America. So if you just irrespective of just say active surveillance, radiation therapy, surgery, what is the cost at 5 years? Active surveillance cost is about $10,000 to $15,000. Surgery is about $20,000, and radiation therapy is about $30,000. So treatment is going to be costly no matter what. Then if you add MRI, still active surveillance is more cost efficient than treatment, despite having an MRI. But I don't know about genomic markers because it's not widely used. So, unfortunately, I'm not aware of any studies comparing adding these genomic markers to the pool of what we have already and see if it makes a difference. Obviously, as I said, it's an expensive test. So it's reasonable to think it will add cost, but does it go way above what we already use for radical therapy? I'm not sure. We have to imagine that the cost of after radical therapy is PSA, but also dealing with the complications of treatment also has a huge cost. No matter if you use medications, if you use needles, if you need an implant, if you need a device to control your leakage, or have diapers on. So,
okay.
I would like to put one question to our colleague. Do you consider a reasonable option to offer a 40-age man who has a family story of prostate cancer to offer him active surveillance if he has criteria, obvious, or on contrary to offer them a study of genomic score to offer a definitively therapeutic?
So I think if they fulfill the active surveillance criteria, you can maybe a bit like more. I would be not hesitant to offer it. If you tell me their family history is significant for dying of prostate cancer or early onset prostate cancer less than 55, then I will send them for BRCA mutation testing. And these are the ones that if the family history is significant or the volume of disease is kind of over what we usually offer active surveillance for. Let's say they have 5 or 6 cores or a couple of cores, but they are 100% full of tumor, meaning the volume is really high, then I will consider offering them genomic markers just to make sure that basically to make myself happy, and more importantly, the patient, that even if your genomic marker shows that you're safe, probably active surveillance is safe for you, and we can follow it. The other thing that as I said, you don't have to use genomic markers. There are other markers you can use. But the problem is changes in these markers like PCA3 or 4K score. Although having a high initial either of these two markers is associated with risk of progression and adverse pathology, but changes in the score doesn't really correlate with risk of progression. So to answer your question, I will feel comfortable offering it. We actually have patients as young as 42 who are on active surveillance. I think on one of my slides I showed in the past few years we had a 33-year-old who was diagnosed with prostate cancer is on active surveillance. And unless there is a huge red flag in their family history or in their biopsy, I think it's reasonable to offer it to them.
To finish my questions, cool. I would like to put a provocative one question.
Sure.
Can we assume that the true Gleason 6 is not a cancer?
Well, so I think if you want to, that's a more philosophical answer to your question is there are a lot of cancers that we are over-treating. Thyroid cancer, breast cancer, and prostate cancer. And interestingly, the rate of overtreatment of breast and thyroid cancer is much, much higher. I know the thyroid group actually got rid of low-risk, low-grade cancer and just call it basically high-risk. I can't remember its term, but to completely omitting prostate cancer from the low-risk prostate cancer from the spectrum of cancer, I don't think we are there yet, mainly from a political standpoint. If you take away low-risk prostate, if you take away prostate cancer, especially low-risk prostate cancer, out of the spectrum of cancer, half of the urologists will be having nothing to do. The other thing is there are still Gleason 6s, although I mentioned it earlier, that they may act differently. And for that reason, until we have better markers to show that a Gleason 6 is really 6 and it's not going to change, I still think we should include low-risk prostate cancer as a cancer.
Thank you.
You're welcome.
Okay, thank you very much. I'd like to thank to the great moderators, Professor Lima and Dr. Ferrito. I'd like to thank you all that were in this session. We had over 200 registrations, so I hope you enjoyed. Thank you for the questions. And of course, thank you, Arlen. I hope to see you soon, maybe in Portugal. Maybe we can invite you to join us 1 or 2 days for some talks and some meetings. And I hope to see you all. We will still continue in these prostate cancer talks, and we'll see you on the 21st of October with another star rising urologist, that is Zach Klassen, talking about non-metastatic CRPC. So I hope to see you soon. Thank you very much, all of you, and I hope to see you soon here. Thank you, everyone.
Thank you, everyone, and thanks for joining us. Have a good one. Take care.
Thank you.
Thank you.
Bye.
Bye.
Thanks.